Hello, my name is Mirrakhimov. I'm a cardiac anesthesiologist and a PACU rotation director for the University of Kentucky Anesthesiology residency program. And today we'll be discussing hypotension and hypertension management in the PACU. I have no conflict of interest in regards to this talk. So what is our agenda for today's talk? We'll start with discussing some of the risk factors for postoperative hemodynamic derangements. We'll also discuss the differential diagnosis and approach to management of postoperative hypertension as well as hypertension. First, let's talk about the disclaimer. The clinical case scenarios which are presented in this talk are only for educational purposes. Any resemblance to real individuals or medical situations is purely coincidental. Do not use this information as a substitute for professional medical advice, diagnosis, or treatment, and always consult with a qualified healthcare provider regarding your specific medical concerns. Let's start with a question. Which of the following factors is associated with a high risk of postoperative hypertension? A. Hyperlipidemia. B. Mild bronchial asthma. C. Mild pulmonic valve regurgitation. And D. Hip fracture surgery. Feel free to pause the video if you need more time to answer the question. And the correct answer is D. Hip fracture surgery. Hip fracture surgeries are often required in patients who are elderly and have multiple medical comorbidities. And these are the surgeries which are often time sensitive in order to minimize the risk of complications. Mild pulmonic valve regurgitation is quite common in normal population and by itself is not a risk factor for hemodynamic instability, which is also true for mild bronchial asthma and hyperlipidemia. So, what are some of the risk factors for postoperative hypertension? Emergent and urgent surgery, like we discussed in the previous question. Presence of cardiac disease, such as long-acting coronary artery disease, significant valvular heart disease, such as, for example, aortic stenosis, history of high blood pressure or hypertension, history of strokes or cerebral vascular accidents, chronic kidney disease, type of surgery, such as, for example, abdominal, cardiothoracic, and vascular, and also surgical blood loss. Anesthetic technique has a role as well, such as neuraxial anesthesia may be associated with high risk of hypertension, especially if high. And obviously, administration of long-acting agents, whether long-acting anesthetics or long-acting antihypertensives during anesthesia. So let's define hypertension. Classically, it is diagnosed when the systolic blood pressure is less than 90 millimeters of mercury. However, it's important for us to remember that non-invasive blood pressure cuffs typically measure mean arterial pressure directly and then indirectly estimate the systolic and diastolic pressure. Again, some patients who are hypertensive at baseline, they can develop hypertension when systolic blood pressure is above 90. For these patients, we go by a blood pressure decrease of at least 20% below baseline. Another important question to ask ourselves, is this blood pressure associated with signs of poor organ perfusion, such as, for example, decreased urine output, mental confusion, or chest pain? Also, it is important for us to know the mean arterial pressure because it's believed that mean arterial pressure is very important for organ perfusion. And there are different formulas which we can use to derive the mean arterial pressure, with one being 1/3 of systolic plus 2/3 of diastolic. And in the vast majority of patients, mean of less than 65 is considered to be hypertension. So how to approach the diagnosis or diagnostic approach to hypertension? It is helpful to break it down into 4 main categories, such as hypovolemia, distributive shock, cardiogenic shock, and obstructive shock. And we'll talk more about these categories later in the lecture. So let's start with a case. You're called to see a 56-year-old male is a history of high blood pressure, who is recovering in PACU after a partial hepatectomy for liver cancer. The patient is awake and complaining of moderate abdominal pain. His blood pressure is 80 over 50 with a mean arterial pressure of 60. He has an arterial line which is appropriately leveled. We performed a point-of-care ultrasound. And what's your impression and how would you manage this patient? So here's your subcostal IVC view, and you see that the heart is hyperdynamic and the IVC is quite collapsible. And here's your parasternal short axis view, and you see that the patient has significant left ventricular hypertrophy, and you see that the LV cavity obliterates. And combined is a finding of IVC collapsibility and cavity obliteration during systole, you strongly suspect hypovolemia. Remember, this patient underwent a liver surgery, and quite often they manage these patients with low intravascular volume status, and also there's a possibility of surgical bleeding. So how would you manage this patient? You'll give him volume, reassess him, consider laboratory analysis such as complete blood count or ABG. You'll also notify the primary surgical team and the regional anesthesia team for their input. Let's do another case. You're called to see a 61-year-old male who has a history of hypertension, diabetes, and coronary disease, who is in the PACU after his femoral popliteal bypass surgery. The patient is awake and complaining of moderate post-surgical pain. His blood pressure is 80 over 50 with a mean pressure of 60. He also has an arterial line, and the arterial line is properly leveled. You perform point-of-care ultrasound. What is your impression, and how would you manage this patient? So here's a parasternal long axis view. Here on top of your right ventricle, aortic valve and LVOT, left atrium, mitral valve, and left ventricle. And next image, you have your apical four-chamber view. And what you can see here, that the left ventricular systolic function is significantly and diffusely decreased. So how would you manage this patient? You would consider addition of inotropes and pressors, rule out new process such as arrhythmias, for example, and coronary ischemia, and will get 12-lead EKG. You will also consult his primary surgical team and primary anesthesia team if necessary. Let's do another case. You're called to see a 31-year-old male who has a history of substance use disorder and chronic hepatitis C infection. The patient is recovering in the PACU after left upper extremity brachial vein abscess surgery. A right subclavian central line was attempted due to very poor peripheral access. The patient is awake and he's complaining of moderate post-surgical pain and also has some shortness of breath, which is unfortunately getting worse. His blood pressure is 80 over 50 with a mean of 60, and he has non-invasive blood pressure. His oxygen saturation is 95% on 5 liters nasal cannula. Again, you perform point-of-care ultrasound. What is your impression, and how would you manage this patient's hypertension? So here is the left lung ultrasound. Here you see some shattering from the ribs, and you can see that the lung or pleura is sliding quite well. And here is the right lung, and here you can see that though the pleura is shimmering, it stops at a certain point. And this is called a lung point, which is a relatively specific finding on ultrasound for pneumothorax. Again, here's the next slide showing you a chest x-ray of a right-sided pneumothorax. It's quite significant here, and you can see that the mediastinal structures in the trachea are quite squished and move towards the left side. And you can highly suspect that this patient has significant hemodynamic compromise. And again, you cannot definitely say that it's a tension pneumothorax because tension pneumothorax is primarily a clinical diagnosis, but you highly suspect it. So how would you treat this patient? Again, you would support him with higher oxygen source, and you will consider doing a needle decompression followed by a chest tube, either by you if no one else is present, or by surgical team. There is another case. You're called to see a 37-year-old male who has a history of recurrent nephrolithiasis, and he is recovering the PACU after a stent placement in his ureter. He is awake but confused, and he is complaining of chills. His blood pressure is 80 over 50 with a mean arterial pressure of 60 via non-invasive blood pressure cuff, and his oxygen saturation is 99% on 2 liters nasal cannula. You performed the point-of-care ultrasound. What is your impression, and how would you manage this patient's hypertension? Here on this slide, you see a parasternal short axis view of the heart, mid-papillary level. You see that the left ventricle is quite hyperdynamic with almost obliteration of the LV cavity and then systole. Here on this particular view, you see that the IVC is relatively full and minimally collapsible with respiration, which makes hypovolemia less likely, and given his recent surgical procedure and high risk for sepsis, you suspect that this patient has septic shock related to his urinary tract source. So how would you manage this patient? You will utilize fluids if necessary and consider vasopressor support, such as norepinephrine, for example, and also you will consider placing an arterial line. As you may remember, this patient doesn't have one. So what is a general approach to management? Like in most situations, it's important to assess the urgency or emergency of the problem. Again, what's the degree of hypertension? Does the patient have any symptoms, such as, for example, is the patient awake, or is he confused, or is he unconscious? Does the patient have pulses? And if you have any concerns, please call for help early. Again, it's important to know what vascular access does the patient have and whether this access is functional, because you will need this access for monitoring, such as arterial line, and for resuscitation if needed. Again, if time allows, verify the measurement. Make sure that the transducer is appropriately positioned and leveled. Again, review the anesthetic record. For example, what medications were given, what was the intraoperative course, how much fluid did the patient receive, including the blood product administration. Again, perform a focused point-of-care ultrasound. And again, if unclear, consider administration of a small IV fluid bolus, such as 250 to 500 cc's, plus minus low dose of vasopressor if needed, such as, for example, phenylephrine 50 to 100 micrograms. Let's talk about some parameters which we can utilize to help us understand whether the patient is fluid responsive or not. Pulse pressure variation and stroke volume variation can be used in some patients. Just to remind ourselves, pulse pressure is the difference between the systolic and diastolic blood pressure. The theory behind is ventricular interdependence. On the top left of the slide, you see a diagram explaining the pathogenesis or pathophysiology of this one. However, this is not appropriate to be used in patients who are not mechanically ventilated, and if you have a patient who is mechanically ventilated, he or she has to be getting at least 8 cc's per kilogram of tidal volumes and be in a sinus rhythm. So this will be unfortunately a minority of patients in the PACU. Let's talk about limitations of pulse pressure variation and stroke volume variations. Patients who are spontaneously breathing or triggering the ventilator, patients with cardiac arrhythmias with increasing intra-abdominal pressures have false positive results. Patients who have tidal volumes less than 8 cc's per kilogram, poor lung compliance, such as patients with ARDS, or patients who have very high respiratory rates, can have false negative results. On a very special note, patients who have right ventricular dysfunction often have false positive results for PPV and SVV, which may make you think that the patient will benefit from volume in the setting of hypertension. However, patients who have right ventricular dysfunction typically do not do well with volume loading, so it is quite important for us to remember that. So what about inferior vena cava or IVC ultrasound? Unfortunately, it has limited sensitivity and specificity. Delta IVC, or change in diameter of at least 12%, is associated with potential fluid responsiveness, in patients who are mechanically ventilated. Again, like in most things in medicines, extremes in values may be helpful. Some other limitations include off-axis imaging and some time required to perform the procedures. Nevertheless, there is some association between different IVC diameters and estimated CVP or central venous pressure, which is present in the table. Please take your time to review this table. So let's talk about the hypovolemia, which is by far the most common cause of postoperative hypertension. The reasons behind that could be surgical blood loss, restrictive fluid administration intraoperatively, prolonged fasting prior to procedure, pre- and postoperative fluid loss, such as, for example, diarrhea or bowel preparation for certain surgeries, vomiting, or diuresis. It is important to assess these patients clinically and utilize point-of-care ultrasound whenever appropriate. Consider laboratory testing, such as, for example, complete blood count. However, it's important for us to remember that in the acute setting of bleeding, CBC will not immediately reveal anemia. And again, consider volume replacement, including the blood transfusion if necessary or bleeding is suspected or confirmed. And again, consider administration of vasopressors to help you buy time and maintain perfusion. And again, notify the surgical team and the primary anesthesia team if appropriate. So the next topic is distributive shock. And again, primarily it's due to decreased vascular tone or systemic vascular resistance, the most common etiology being sepsis. Also, anaphylaxis and anaphylactic shock are quite important for us in the perioperative medicine area. Also think about adrenal insufficiency, for example, patients who are taking high-dose glucocorticoids chronically and come for surgery. Again, high neuraxial block, and also think about the medications which were given intraoperatively, such as long-acting antihypertensives, for example. So how do we approach the management of distributive shock? Of course, it is important to treat the underlying cause, such as, for example, epinephrine for anaphylaxis and removing the offending insult, antibiotics and source control for sepsis, IV fluids if the patient is deemed to be fluid tolerant, vasopressors, calcium, and modifying uraxial infusion if it is present and considered to be a potential contributor to the hypertension. So let's talk a little bit about the cardiogenic sources of hypertension. Every time consider a new ischemic event, think about possible arrhythmias which are either contributing or causing the cardiogenic event. Think about LAST or local anesthetic systemic toxicity in the appropriate scenario, because a lot of these patients are considered to be high risk for that. Always obtain a 12-lead EKG, looking for new arrhythmias or ischemic changes, and treat the underlying cause. For example, pacing for bradyarrhythmias, cardioversion for tachyarrhythmias, and revascularization for new ischemia. So what about obstructive shock? What do we mean by obstructive shock? Basically, when there is an obstruction of blood flow from the right side of the heart to the left side of the heart. When I think about obstructive shock, I think about tangent pneumothorax, major pulmonary embolism, pericardial tamponade, which is present on this echocardiogram. And the treatment is supportive and focused on the underlying cause. For example, decompression for tamponade via pericardial drain placement and decompression of pneumothorax via pleural drain placement, and thrombolysis for pulmonary embolism. So let's talk about vasopressors. On this slide, you'll see the most commonly used vasopressors in clinical medicine and anesthesiology. Most of these vasopressors act on some form of adrenergic receptors, such as, for example, alpha-1 and beta-1 for norepinephrine, and, for example, only alpha-1 for phenylephrine. Epinephrine, compared to other agents, has significant inotropic activity, and vasopressin acts on vasopressin receptors. It is believed that vasopressin, compared to others, doesn't typically affect or increase pulmonary vascular resistance and can be a nice, useful agent for patients who have pulmonary hypertension. However, it can cause hyponatremia due to chemical similarities to antidiuretic hormone. Let's do another case. You're called to see a 65-year-old male patient in the PACU with status post-ERCP for cholangitis. He was extubated and is requiring low-dose norepinephrine infusion, which is 0.04 micrograms per kilogram per minute, via his 20-gauge 4-arm peripheral IV. However, the patient is experiencing worsening pain at his PIV site and some subjective swelling. You went to see the patient, and here's what you see. What is your approach? So unfortunately, our patient experienced an extravasation injury. In a case like that, first you stop the infusion, you try and aspirate the IV with the hope that you'll be able to get some of this medicine out of the system. You inject phentolamine, which is an alpha-1 antagonist around the IV site, even consider giving it through the extravasated IV. Typically, you dilute 5 to 10 milligrams in 10 cc's of saline. You can consider nitroglycerin patch. You need to think about an alternative IV access for this patient. Mark the area of swelling to monitor for progression. Consider elevating the limb and notify the primary surgical team. It is important for us to remember that phentolamine will not be effective for a patient who developed vasopressin extravasation. That is one of the reasons why vasopressin is not typically utilized via peripheral IV access. Let's do another case. You're covering for a 35-year-old patient in the PACU after a awake craniotomy. He is awaiting ICU bed. He is doing pretty good and has no complaints. His blood pressure is quite high, however, with a systolic being 180, diastolic 100, and MAP of 127. The first question is, are you concerned about this blood pressure value? The answer is yes. This is a patient who is after craniotomy and thus has a high risk of intracranial hemorrhage. What is our next step? Give labetalol, start nicardipine, give hydralazine, or check the monitoring equipment. And since the patient has no symptoms, it is also quite important for us to verify the measurement. As you may remember that every 10 centimeter leveling error in the transducer will lead to about 7.4 millimeters of mercury monitoring error in measurement. For example, if you see that the transducer is on the floor, which will support our suspicion for measuring problem or measuring error. So what is hypertension or high blood pressure? Again, classically it is defined as blood pressure more than 130 over 80. It is important for us to remember that we need to keep mean arterial pressure within 20% of baseline, unless there is a conflicting reason not to do so, such as, for example, intracranial surgery or major cardiovascular surgery. When thinking about how to approach hypertension in the preoperative area in the PACU, it is also important to know the context. For example, what kind of surgery this patient had, such as CNS surgery or brain surgery, cardiovascular and thoracic surgery. These patients may need special blood pressure goals. And again, what kind of a pathology does the patient have? Does he or she have vascular dissection or aortic dissection? And do they have target organ damage, such as, for example, stroke and acute kidney injury? What is a typical etiology of hypertension in the PACU? A lot of these patients will have a history of preoperative hypertension, and some of them skipped certain medications, either because they were told to do so or forgot to take them. Pain is important to think about and often overlooked. Gas exchange derangements, such as, for example, hypoxemia and hypercarbia, postoperative nausea and vomiting, shivering, delirium and substance withdrawal, for example, alcohol withdrawal and opiate withdrawal. For example, certain drugs or abuse can lead to PACU hypertension, such as, for example, amphetamine use or cocaine use, and recent pressor administration, whether intentional or unintentional due to medication administration error. Bladder distension is another very important factor to think about, and hypervolemia. That's why it's important for us to review the intraoperative record as well. So what is an approach to management? Again, like we discussed earlier, confirm the measurement and assess for urgency. Treat the underlying cause, such as, for example, treat the pain and resume antihypertensive medications if no contraindications. And again, think about, does the patient have possible hypertensive emergencies, such as in the presence of cardiac ischemia, CNS dysfunction, or presence of aortic dissection. So let's discuss some of the IV antihypertensive we can use to treat perioperative and PACU hypertension. On this slide, you see beta blockers such as esmolol and labetalol, and calcium channel blockers such as nicardipine and clevedipine. Labetalol is not a pure beta blocker because it has some alpha-1 blocking activity. The onset of action is much faster with esmolol, and the duration of action is much less with esmolol as well. Labetalol takes longer to kick in, but also stays longer in the system, which can be good and bad depending on the circumstance. Nicardipine is longer acting compared to clevedipine and takes a little bit longer to kick in. And clevedipine is much faster in onset, but also lasts much less. Again, like in the case of esmolol and labetalol, it can be good and bad depending on the circumstance. Also, please pay attention that there is a certain risk involved with this medication, such as, for example, AV blocks and reactive airway disease with beta blockers, and flushing and tachycardia with calcium channel blockers. We'll keep talking about IV antihypertensives. On this slide, we have three medications, such as nitroglycerin, sodium nitroprusside, and hydralazine. Nitroglycerin and sodium nitroprusside, they mediate the vasodilation via nitric oxide. Nitroglycerin is slightly more potent venodilator, and sodium nitroprusside is more potent arterial dilator compared to nitroglycerin. Both of these agents are associated with some side effects. Classically, sodium nitroprusside is associated with cyanide and thiocyanide toxicity, as well as methylgalvanemia and hypoxemia, which can also be seen with nitroglycerin. Hypoxemia is believed to be due to ventilation-perfusion mismatch. Hydralazine is a direct arterial vasodilator. This agent has relatively slow onset of action and has unpredictable response and potential for tachycardia. It is important for us to remember that whenever you're using IV antihypertensives, it is important to consider placing an arterial line for better and more accurate continuous blood pressure monitoring. On this slide, we discuss sodium nitroprusside toxicity. On the table, you see that it can lead to cyanide, thiocyanide toxicity, and methylgalvanemia. Please take a look at the risk factors and presentation. And on the right part of the screen, you have a pictorial showing the chemical pathways and mechanisms of sodium nitroprusside toxicity. Let's take a time to review this picture. So in conclusion, postoperative blood pressure derangements are quite common, which is true for both hypotension and hypertension. Assess the urgency of the problem and verify measurements. Treat the underlying cause, for example, antibiotics and source control for sepsis, and analgesia for pain-related hypertension. We need to know common vasoactive medications, their nuances and contraindications, which is true for both antihypertensive medications as well as pressor medications. Thank you very much for your attention, and good luck.